Hi, I'm Dale Sherbeck, and welcome to the HQ, a CHA Learning and Healthcare Can podcast serial where we dive into healthcare issues and topics from the perspective of its people and discuss them with those that are leading in the health system. Together, we'll try to unpack these topics and learn what actions are being taken to innovatively solve them today. Welcome back to my conversation with Tony Bennett and Steve Ashton as we continue the conversation about Canada's health workforce data. I think that sort of leads to some other questions for me as well. And one is that I know in conversations I've had with you over the years, Steve, one word that you use very often is the word benchmark. And right, but I think the other one, as you've both been alluding to, is the issue about forecasting. So, so maybe just building on what you've just been talking in terms of, I guess, what our current data sets are, what our potential uses of it, and the questions about design. Where did those two words, I guess, come in, and how do you sort of see them here? So maybe I'll throw it back to, well, let me start with you, Tony, maybe, and get your perspective on that.
Yeah, well, I mean, the benchmarks, again, I'll draw the parallel to the compensation side, right? You, you benchmark against yourself, and we do this with our own too. You look at your overtime rates, right? Are our
Mm-hmm.
overtime rates high or low? Ours are higher compared to what they were pre-COVID 2 years ago, whatever it happens to be. So for ourselves, we know we need to take some steps to try and address that. Part of that is digging into the why. But
Mm-hmm.
the benchmarking also goes in, and we look at, is our experience similar to what other organizations are seeing across Canada? In that, is that something that we've just experienced on our own? And as we go through and even look at the recent survey and that sort of thing, we suspected it was no. We were suspected that others were dealing with that as well. But and we've seen that over time has increased in other organizations. Has it? But then we can start learning from that as well. You know, has our overtime rates, as you said, benchmarked? Are we higher or lower? Why? What can we do? What might we be able to learn from Steve? Because Steve's overtime rates have potentially only gone up, a couple of points, where ours have gone up many points. So Steve, what are you doing? Like,
Right.
what are some of the ideas that you've done to kind of help reduce it? And again, it gets that conversation and curiosity leads to solutions, right?
Mm-hmm.
And by that learning, it's not like we in AHS are competing with Steve, right? That's where it's different from the compensation world. We're not competing with Steve on the solutions or the people and that sort of thing, but we can share the learnings so that there's that mutual broader benefit to those that rely on the healthcare system. So from that perspective, as another way to kind of go through and learn, by building that knowledge out nationally, we can bring it back to our own organizations to improve, which ultimately has that benefit on our patients and their families at the end of the day. So the benchmarking is key. It's necessary as we're going through and looking at that as a learning tool. It's any part of organizational performance management is kind of being able to go through and benchmark around that. As to the forecasting, and that, again, just drawing on our experience, starting with walking, right?
Mm-hmm.
Let's if we've got a good base, then we can start thinking about what are some of the projections and forecasts and that sort of thing. But we've got a lot of questions to answer and a lot of work to do, even to kind of look at that base. Even as we saw going through the last workforce survey, right? What we call a head count is not necessarily what Steve counts as a head count, right? So there's some of that base language
Mm-hmm.
that we need to kind of go through and set. It doesn't mean it has to be our way or Steve's way or Gary's way, but it's just a common understanding of that language as we're talking, so that when we are having those conversations with each other, that we can help, that we do have that opportunity to kind of go through and understand and then learn.
Thanks, Tony.
Now, I would agree 100%. I mean, the way we look at benchmarking is very much the same way that Tony looks at it. It's it starts with, well, actually, I always think it starts with the question of, I'm in a car, I can't see out the windows, I have no dashboard, I have no mirrors, and I actually don't have any motion detection that gives me feedback as to whether I'm moving, let alone what direction I'm driving in, whether I'm going to hit something or not, et cetera. And when you start from that basis, it's kind of scary. So whatever you can start with is a good thing, and pick one metric. If you're starting from scratch, just pick one metric and start, but explore it. Like, I would encourage somebody not to get a scorecard of 50 metrics to start with.
No.
I'd say start with one and just work that muscle, because take to your point, benchmarking and all those things. you know Benchmarking is a funny one. I would say, yeah, absolutely, internally benchmark. I mean, if you're in an improvement culture, you want to start by, first of all, getting better than you are. To get better, you also kind of want to know, well, what is good, right? What's
Hmm.
good in my context, but not only in my context, what's good in other contexts. We talk about being high reliability organizations in healthcare, but there are other industries that have been at it way longer than we have. If you actually want to compare safety records and discipline and culture, healthcare is not your top one to go to. I wouldn't go to healthcare if I was wanting to. I would be talking to,
Nope.
in some cases, the airlines, the nuclear industry. There's a lot of other high reliability organizations that have developed an incredibly rigorous culture. And it's not because we don't want to be safe and healthy, but for whatever reason you want to make up. But all that to say, so I like to look at internal benchmarks. I like to see how the rest of my peers are doing across the country, and talking to them and comparing notes and finding out why somebody's better or worse than we are. And it might be that we're measuring it differently. I'll give you a really small one, Tony, that came up in our conversation on IWK Health. And we were looking at some of our stats, and we were doing really good in Nova Scotia. And I'm trying to figure out, well, why are we even better than our peers next door? And so it was one thing to have the conversation about how we were doing against other peers in Nova Scotia. But when we went to other provinces, we had to take into account that with our workers' compensation system in Nova Scotia, there's a 2-day wait. So the first 2 days don't count.
Mm.
Now, suddenly, the question you ask yourself is, how does that skew my stats versus a province that starts on day one? So, so you have to get inside of it a little bit and understand it. So suddenly that might have skewed the data altogether,
Yeah.
but it's still, you learn something from it. And then you go to another industry altogether, and I could say, why is the construction industry safer than healthcare? I mean, the weirdest part is, as you do the stats, healthcare is one of the unsafest industries to be in Canada, which would shock most people. And when you ask yourself, did you realize that construction and fisheries have done more for safety, and the oil and gas industry has done more for safety in the cultures, and has fewer accidents than healthcare in many cases? So, those are the things that also provide, I will call it, very, very insightful elucidation as to where you really sit in the world. And that reality check is no judgment to start with. It just says, now I understand where we're at. And now when somebody tells me that we're doing great, I can say, we're doing okay compared to our peers. We're doing better than we were last year, but we could be a lot better. And that just helps inform the conversation. But then the second piece is, as you say, you dig into it. Some of the best conversations I have was when our quarterly scorecard comes out, and I share it with my people leadership team. And you'd think that they're all in the same team, they would have the same insights, but an HR consultant or somebody in staff scheduling, or then you go talk to your clinical managers, will tell you stuff that will just completely change your thinking on what moves a particular metric, or what's causing you to go in a certain direction.
Yeah.
I find that awesome, and it just creates better conversations. It creates better policy as you move forward. It creates better support systems. It's why I get kind of pumped and excited about it. And you can actually measure whether you're making a difference. And it's way better than sitting in a car with, no windows, no dashboard, etc.
So speaking of getting excited, I mean, you both describe yourselves as, as people who get excited and curious about the data. So we've established that you see the value in it, but what is changing with respect to how others inside your organization are treating this as well? So has there been any, you know, changes in terms of the way other healthcare leaders, your CEOs, your COOs, right, other leaders that you're working with around your leadership tables are looking at HR data today that they weren't 3 years ago?
Yeah. I'll just jump in, Steve. I want to build on what you said before, that, today alone you've dealt with three requests for workforce information or that as well. Um, Ours is very similar, right? Before COVID, 3 years ago, we would get a lot of requests for what's the information, what's the story kind of behind this.
Hmm.
That's just grown exponentially as I think the organization, they've always known, right, the old cliche, of our people, right, are what drives the business that makes us successful. But as we've gone through and as we've faced some of the various workforce challenges and such that we've had, they've realized that they need that foundational information, at
Hmm.
least and then not just that, but they also need the story behind it as well. So much like you, Steve, we do our best on trying to go through and provide not just the data or the information, the numbers, the stories, but it's become a big challenge, and we're trying to find ways to um, you know teach the people to fish, right? So
Hmm.
that they can go and find some of that base information and then come to us and help. We can help them um, figure it out, or what does this mean, or what are the forecasts or projections, that sort of thing. So it is shifting how we're trying to shift how how and when people are coming to us. And I think that's a shift in the organization as well, that, again, I'll circle back to the importance and the value of that good foundational evidence that we've got around our workforce.
Yeah. And I would echo, I mean, I'm excited because the conversations we're having about health human resources and related questions is
Yeah.
probably never been more prevalent. And not just for the people who are always interested in it. To your point, your CEOs across the country are asking for it. Your politicians are paying attention
Hmm.
to it. I mean, when a
Yeah.
politician is in the House talking about um, the importance of not only that we have enough healthcare workers, but they're pushing that we want to ensure that we have healthy and feeling safe. We're having conversations about equity in healthcare and data to back up and inform and shine a light and improve and change and bring real change. And obviously, one of the things I'll give credit to healthcare. We talked about the plethora of data, but I mean, the one thing where healthcare always was very sophisticated is more on the patient safety side and the obviously the research into what improves outcomes, and finding HR at the same, I would say, getting very close to being at the same level in the organization today is really exciting. Because I
Yeah.
remember when I came, I used to say, patient safety's up here, and staff safety's down here. And that would just be a
Hmm.
small example of just the slightly differential way we looked at our own people versus the patients and families we serve. In no way do you want to reduce the focus on improving patient safety and patient care. But we've now changed the conversation about how to do that. You absolutely need to ensure that those who are providing the care and those who are supporting the ones who are providing the care, that you've got enough of them, that they're healthy, they're safe, they're well, and they reflect the communities that they're there to serve. And that is, we're at a place today where we weren't 10 years ago. And that's kind of what keeps you going is, not just the data and getting excited about the data, but is it telling stories? Is it helping influence policy and planning in a way that changes people's lives for the better? That's the kind of stuff that gets you up in the morning.
Yeah, so the light bulbs are going off for some people in terms of what, perhaps some things that they've been told for some time, right? And even I think even the story that you just shared, Steve, I mean, the connection between um, healthcare worker safety and the safety of patients are actually connected too. So, so I mean, yeah, if people are starting to see these things as being important and how they ultimately shape the success of our businesses, right, and the provision of our services, then that can only keep leading us in the right direction. So, speaking of politicians and such getting excited about data, um, you know, I mean, even I think it's the survey that you've described, both of you have referenced that we did at Healthcare Can, um, in the fall, and that sort of tried to give us a sense of what was happening nationally in in the undertaking of that, we were getting a lot of different comments back from our members saying, we'd like to participate, but I'm overwhelmed because the ministry is asking me for this. My CEO is asking me for this. Like, everybody's asking us for data now, right? The number of requests that are coming suddenly, and so they're trying to balance all of that. And I suspect that you can both attest to that, and you specifically, Tony, who you and your team are having to answer those requests. So,
Yeah.
what are they all trying to solve? Like, what is the point of all this? Like, what is the collective problem that we are trying to solve through these kinds of requests?
Yeah, I think one is, well, thinking about some of the questions we're getting now, the question is, help us define how big the problem is,
Mm-hmm.
help us connect that to um, what happens when this problem isn't solved. Then help us understand why we have this problem and help us understand what things could improve the problem. So let's just take vacancy rate, for example, which is the first thing on our report. And it says is we based on our survey nationally of all the participants in it, the average vacancy rate was 12.4%. Well, that's astounding. I mean, for my organization, if I did the math on that, 12% of a 3,400 person workforce is there's 360 positions that are not filled right now.
Mm-hmm.
And if those aren't filled, and you want to get specifically where they're not filled, I mean, we're often asked about specifically nursing shortages. And if you ask me what department that's in, and then you get it right down to that level, I would say this would be very common to just about every one of my colleagues across Canada. If you ask that question and drill down that far, we'll tell you ED nurses. I think
Mm-hmm.
that'll echo across the country. We are struggling to recruit and retain experienced ED nurses. So that pretty well gets your attention. And suddenly the question is, well, great, what do we need to do to solve that problem? And and the solution isn't a single solution. It leads to the conversations we're now having provincially and nationally. It means you need to ensure you have a good funnel of new grads coming out, but new grads aren't going to solve all your problems. Secondly, you might bring retirees back, people who already had experience and are recently out of the workforce, but can come back and step in to help out. Third piece is how are you training and developing the existing ones? We're talking about immigration and how we can, improve and streamline our ability to find, qualified candidates from around the world who may want to live and build their careers here. And also once they can land here, how do we streamline that to the point where they can, and all those points we can bring data to inform. The bigger thing we were talking about earlier was then also help to realize how many do we need. Maybe there's some design things that we can change as well. So the question then takes you to, well, how are we doing with nursing across the rest of the organization? Oh, you mean we've got other units who might actually have some capacity to help out in the short term. Okay, what do we have to do that? Oh, we might have to work with the unions to adjust the way we redeploy the workforce or reward them for that, for helping out in those cases. And that may lead to other conversations. So, the cool part is I've just picked on one number and one stat, but it led to so many conversations. And I'd tell you that's an example of the conversations that are leading to recruitment, retention, immigration, training and development, and completely rethinking models of care and staffing models for our organization. That's kind of revolutionizing, like COVID revolutionized for us. It's kind of broken the mold that we were in that said we can only do things certain ways. Because honestly, before COVID and before we hit this crisis, there were a lot of people who wanted to keep things exactly the same way for all sorts of different reasons and motivations. But we blew it up. When you get to a point where you've got that kind of a vacancy rate, you can't just keep doing things the old way. So it's created an incredible amount of innovative thinking and new tools in our toolkit that I think are really going to be helpful as we try to recast how we deliver healthcare in this country.
Thanks, Steve. Tony?
Yeah, Steve hit the nail on the head there, right? It's that the conversation that's going on, even within provinces or across with the federal, and the information to government, it's not just something that the healthcare authorities or identities or hospitals can kind of go through and deal with on their own. Because it is broader and it is systemic, right? As Steve said, we need to, the broader we, outside of just our own organizations, need to look at, as you said, how are we bringing people into the profession? None of these are quick fixes, right? How are we bringing people into the professions that are needed? How are we incenting them to work in the areas that we need them to get to? And more importantly, as you said, Steve, how do we change the way that we work going forward in a way that still provides that best care to the patients and families, but just because we've done it, with method A, do we keep doing that for the next 90 years? I would hope not, right? And I think the work that we've been doing in this HR data, the HR analytics, and the workforce planning side of things, especially building the workforce strategies, is going to provide that guidance in the path for individual organizations. As long as we keep having these conversations nationally, that'll drive that national conversation as well, which I would hope then helps the governments, be they provincial or federal, do what they can to kind of enable those changes, be it professional regulations or post-secondary seats or whatever it happens to be around that way.
So great segue, Tony. In terms of, so as governments are getting involved in this and making other sorts of announcements. So in light of the announcement, so in terms of timestamping this podcast episode that came out last week on February the 7th by the PMO and Prime Minister Trudeau's, his office made the statement that the Government of Canada will provide $505 million over 5 years to the Canadian Institute for Health Information and Canada Health Infoway and the federal data partners to work with provinces and territories on developing new health data indicators and to support the creation of a Centre of Excellence for Health Workforce Data and underpin efforts to use data to improve healthcare. So we don't have a lot more information than that statement so far. But imagining, given that you're at the coalface of this, and somebody's making an offer to help or in this space, can we just sort of pull those two parts of that apart a little bit and just get your thoughts and opinions on it? So the next one may be a bit rhetorical given the course of the conversation that we've just had for the last almost hour, I think. That, do we need a health workforce data sharing strategy? And if so, why and what will it do? And then maybe let's have that conversation first, and then we can come back to the second part around the indicators piece. So who wants to take the first part of that?
I can take a stab. I think the important piece out of that, and we've talked about this before, just a little bit earlier as well, is creating that common language, which is then having that base health HR definitions, if you will, and data that we can kind of go through and then build the benchmarks, and all those tools are going to enable that conversation. It's harder to kind of think again, where and how that federal money that they've kind of talked about kind of feeds into all of that. But I think if that's where some of that kind of goes, I think that's going to help build out everything that we've been talking about, as you said, for the last hour or so, that needs to happen to be able to further that conversation and that collaboration across the country.
Okay, thanks, Tony. And so the second part of that question is the development of so-called health indicators on our health workforce. So here's your wish, right? You get to be influential people right now. They're going to do it. What indicators do you want them to develop? Give the federal government some advice here, or Kai.
Yeah, it's an interesting conversation because it's going to start with, I think in my mind, Tony, you're probably going to the exact same place. What problem are you trying to solve? and that will
Yeah.
dictate what kind of metrics you want to start to measure. I mean, I know within my organization we've got a scorecard, the quarterly scorecard that has, 10 indicators on it, and that's as much as we'll do. There can be sub indexes or sub things that we can dig into if we need to, but just that one page that we can give our board and we publish on our website quarterly that tells you how we're doing on some of the big items. And some of them, are really important to us. So, for example, we're going to want to know time loss injury rate for the organization, and we're going to want to know, we have specific ones around performance reviews and talent reviews to make sure that we're investing in our talent. Those ones, the talent review ones, I'm not sure are going to be of interest at a national level. The time loss injuries, there's a lot of data on that already. And I mean, is that the one where you want to spend most of your time? We might decide in healthcare that it's worth having a couple of indicators. We're using, injury rate and durations. I would say durations may be one that I would push even over injury rate, because when we think of the health of our workforce, the mental health and wellness of it, the influence of PTSD and presumptive legislation, coming out of COVID, what the impacts are, there's an enormous reason to want to maybe have a metric for the mental health and wellness of our workforce and how they're doing, so that we can make sure we're investing in that. But some of the other ones, attrition rate, absolutely. Vacancy rates by profession, absolutely. We're going to want to know, because on an intervention level, we need to know that we've got a healthy workforce, that we're producing enough people in the right roles, professions, and that if we need to turn the tap on or up or down, that we've got something that can do that. I mean, we talked before that we missed the boat in some form or fashion. Let's use physicians as an example. The crisis we're in today, we predicted years ago when we started shutting down seats and making immigration rules very restrictive. It was a closed system, and you could predict, as people retired and as the population grew and got older, that the demand in the system would grow, and we were shrinking the workforce. I mean, there's lots of examples where you can tell those stories. So I think we do need some of those indicators, but I would start by saying, don't jump to conclusions until you get the people in the room and have a conversation about what problems are we going to try to solve, and what would be of the greatest benefit to the users to have a national database on.
100% agree. 100% agree, Steve. And that's a conversation that we have many times, right? Around, because sometimes it does come that direction. Well, what are we going to report? Well, what do we want to have happen, right? So then, just key ones that and very similar, and it does not surprise me, Steve, that you're looking at very similar things to what we are as well. Overtime is a big one for ours as well, just because again, it's been an area that we've of concern for a while, our increasing overtime rates, and why that tabled with the sick rates, and that kind of speaks to the healthy side of it as much as the injury and the duration side of it as well. But 100% agree with you. It's let's figure out kind of what is it that we're trying to solve, and we can find the right measures for going through and doing that, and seeing if we're making progress, right?
Yeah, I mean, the other one I think we can't ignore, and I really hope becomes part of the conversation, is also on the social justice side and the equity side. I mean, we've got a Truth and Reconciliation Commission that had a series of recommendations in the call to action, and one of the questions is how we doing? It's 5 years out. How are we doing against those? I think we have a responsibility as health leaders to invest in that as well. So when we talk about the breakdown of some of these stats, let's look at the health and wellness of our workforce on a race-based and cultural background. What are we doing in the recruitment and retention? The talent pool that's available. When you start to think about, where are you going to inspire and find the next doctor, nurse, medical lab tech, etc. I mean, we've got incredible opportunities in our Indigenous and our African Canadian communities and our new immigrants. There's huge opportunities, and there's been systemic barriers against those populations participating in our workforce, and as a result, continuing to keep the systemic biases that are built into our systems. So, I think on that front, if you on top of all the other metrics we're going to want to tie into, also start making sure that we are actually measuring and trying to advance on some of the more social opportunities that we have. I think that's the other thing that I think will make our system better, and I think we can feel real good about if we invest in those. So, those would be things that the Prime Minister's office is interested in. We've got huge work to do with our Indigenous communities, as we know right now. In Canada, among many, many others. So imagine your workforce is more reflective of the community and you're holding yourself to that. I mean, interesting enough, the Canadian government was the one that started the Canada 50-30 challenge. That's from mostly at board and senior leadership levels, but what are we doing across the healthcare sector? So I see the sky's the limit. We could dilute this by having too many metrics, but if we could focus on a handful of the most important and the most valuable to us as a nation to improve the healthcare system, that is an awesome conversation. I'm looking forward to having it. As long as Tony, you and I and our colleagues are there.
Absolutely.
I don't want to hear about it from somebody who's not bringing some of the background and passion to that conversation.
Yeah, but I think some great wisdom and advice in terms of what you've both shared. But I do think that coming back to one of your earliest comments, Tony, about that data is just data, right? It has no value unless you're using it for, I guess, ultimately to achieve action. And right, because quite frankly, we've been sitting on some of this data already for a long time. We already knew what the average age of our doctors and nurses were heading into the pandemic. We knew that there was going to be huge numbers of retirements, right? If they weren't compelled to retire faster, that was going to happen anyways. But I don't think anybody was turning the tap on bigger, right, to overcome that. Right. So I think it does, the indicators will be one thing, but what we use those indicators for will surely become the most important thing out of this. So, as we come to a close in terms of this conversation, maybe just leave you with one sort of other, I guess, kick at the can here. If there was anything else that you need, right, if you were, to be presented with an opportunity to speak to the federal government and the ministers there, that were to offer you more help to invest in your HHR and health human resource data, what would you be asking for?
I'll jump in first, Steve, and then I'll give you the last word. And
God forbid, I'm thinking.
Yeah, and I'm afraid, Dale, I'm not going to say anything kind of really new in the conversation. Is what
Sure.
what I'd really ask federal government or anybody who's looking to help this is as Steve just said, come out, talk to the health authorities, and see how these levels of government can help enable these conversations and the tools that are needed for these conversations to happen across provinces, across the country, so that by that collaboration, by that joint knowledge, we can go and learn from each other and find solutions that are going to help deal with the gap and the challenges that we're seeing right now with the healthcare workforce that we are right now. What is that specifically? Is it X dollars to this or Y dollars to that? I think we've got some ideas, but I think we've really got to have some of that conversation. It goes back to what we were saying about metrics: is what are we trying to achieve? Then we'll know where we need that help and that resource to go. So not a solid answer, but that's kind of off the top where I think the directional piece that we need to go. Steve?
Yeah, no, Tony, that's brilliant, and I would agree. I mean, I think, Dale, to the conversations we're having nationally, the fact that we've got the federal government and the provinces having a different dialogue right now, and connected by funding and other things, it has forced the question as to where are you investing and why, and what's the ROI on these investments going to be for the sake of the healthcare system. So I think the fact that we've got that avenue open now is going to give us an opportunity to have a different conversation about where we're trying to get to. So imagine, as this relationship evolves and we've built this greater sophistication around the HHR conversation, that at their annual meetings, they are actually bringing forward some apples to apples comparisons of how the
Yeah.
workforce is doing. I think that's where the real power will come, because again, you come to the table and you don't have any data, or you don't have data you can actually have a meaningful conversation about and make sense of. You just walk away and either throw money at things or don't throw any at the issue. I think this is going to much better help inform the kinds of conversations and the kind of investments we make in the future with our healthcare workforce. And I'm hoping that, we're at the beginning of sort of a new era where we've built the business case, and folks are bought in. Now let's not squander that opportunity. Let's make sure we build the foundations to continue those conversations go forward. So again, if that's an investment in the education system, the graduates that we bring in, if it improves immigration, if it improves healthcare models of care, all sorts of other things. If it improves the investment in research and HHR data. I mean, I'm having a conversation recently with somebody that I was introduced to at a university in another province whose whole focus has been on looking at the impact of remote work and hybrid work on work environments. We're having a conversation about, well, geez, I wonder what the impact of that's been in healthcare. Do we want to do some work together to explore that question? And then imagine sharing that across the country and thinking about how that might impact the design of virtual care and hybrid work within the healthcare system. So it's kind of exciting. But again, back to the point Tony just made, let's start with the conversation of where are we trying to get to, and then figure out what data will help us both set reasonable targets and goals, and then tell us how we're doing on that journey.
Thanks, Steve. And thanks, Tony. I think you've provided us, some really great last words as we sort of wrap this up. But I would say, it's interestingly, maybe not, and not surprisingly, I think you echo a lot of the same things that, in our recent conversation with Dr. Michael Gardam, and talking about us needing to have those conversations about what we want first. Right, and establishing a vision for that before we start making, I guess, the tweaks and the investments in some of these spaces as well, and that ultimately it is going to start with communication and cooperation, and I think both of you have made that explicitly clear in everything that you've shared here. So thank you both for sharing so much of your experience. I hope that as an outcome of this, that you have converted others to become curious about their health human resource data and to follow in your great footsteps. So again, thanks for the conversation today, and wish you both very well.
Thank you, Dale. Thank you, Dale.
You've been listening to the HQ, and I'm Dale Sherback, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.